Welcome back to the Deep Dive. Today we are focusing on one of the most critical, yet I think frequently underestimated measurements in all of medicine, the Crown-Rump length, or CRL. For a long time, dating a pregnancy relied on the last menstrual period, the LMP, which, let's be honest, was a metric famous for its reliance on recall and, frankly, a bit of guesswork.
A lot of guesswork. And that's why the move to sonographic dating, using the CRL was such a massive leap forward for obstetrics. But here's the critical insight, the thing you really need to get right away. This isn't just academic. We are talking about what we call the ripple effect. We found that a dating error of just 3 days, which sounds like nothing, right? It's a tiny embryo.
Sounds negligible.
Exactly. But it propagates and influences the entire 9-month trajectory of patient management.
A 3-day error, it sounds so small, but you're saying that tiny deviation just gets magnified exponentially down the line. Where does that ripple hit the patient the hardest?
Okay, so it impacts 3 major clinical domains. First, it can completely throw off your first trimester serum biochemistry, for aneuploidy screening.
The screening tests.
Right. The expected level of markers, like KPA, is highly, highly dependent on an exact gestational age. If your date is off by even a few days, your risk assessment is compromised.
So the test itself might be accurate, but the reference range you're comparing it to is just wrong.
That's it, exactly. Second, fast forward to the 3rd trimester. That initial dating error dictates whether a fetus is correctly classified as, say, small for gestational age SGA.
Which would trigger a whole different level of care.
Immediate intensive surveillance. Or maybe it gets misclassified because the dates are wrong. You just can't assess growth accurately if you don't know the true starting line.
And then there's the final highest stakes moment, the timing of delivery.
Precisely. That small error governs when you give crucial interventions. Are you giving corticosteroids for threatened preterm labor? Or, and this is the big one, are you deciding the induction date for a post-term pregnancy? Get the date wrong, and you risk iatrogenic prematurity.
Inducing a baby who is actually biologically younger than your faulty scan claims.
Yes. So our mission today is to really move from relying on just, an eyeballed measurement to rigorously adhering to evidence-based standards. We're talking ISUOG, intergrowth 21st, to ensure clinical safety.
We've established the enormous stakes of even a 3-day error. So to prevent that, the sources demand strict quality control. It's not enough to just find the fetus and drop a caliper line on it.
Not at all.
Modern standards, like from ISUOG and the FMF, they insist on a really strict 5-point quality checklist. And if you fail even one of these criteria, the sources say you can immediately introduce areas of 3 to 5 days.
That's right, because these 5 criteria are designed to combat the technical and physics-based errors that are just inherent in the ultrasound process itself. We should start with the imaging setup.
Okay, what's the first non-negotiable?
Magnification. The fetus has to occupy more than 75% of the image width.
Okay, why? Why so specific?
It's because of something called quantization error. If the image isn't magnified enough, moving your caliper just one tiny pixel on the screen might represent a massive, 0.5 millimeter or more in the actual fetus.
So it blurs your accuracy.
It completely blurs your accuracy. High magnification minimizes that. It's like using a microscope for your measurement, allowing for far more precise pixel placement.
That sounds like a real skill bottleneck right there.
Yeah.
If that magnification rule isn't followed, you're compromising precision before you even start.
Okay, what about finding the right anatomical plane?
That's criterion 2, Midsagittal plane. We have to capture the true straight-down longitudinal axis. And to confirm you're really in the midline, the operator has to see specific markers.
Like what?
The echogenic tip of the nose, the rectangular palate, and the translucent diencephalon. These little structures prove you haven't strayed off axis.
And if you're slightly off axis,
What happens?
you'll hit a parasagittal section, and that subtly foreshortens the CRL. The measurement is too short.
Which means the baby is wrongly dated as younger than it truly is.
Systematically underestimated. Then, criterion 3 deals with the position relative to the beam, horizontal orientation. The fetus should be positioned roughly perpendicular 90 degrees to the ultrasound beam. An acceptable range is about 75 to 105 degrees.
And that angle just gives you a clearer picture.
It ensures the crown and rump skin interfaces are just cleanly delineated for the measurement.
Okay, so now we get to the calipers, which seem, I don't know, notorious for causing problems even if the image is perfect.
They are, indeed. So criterion 4 is caliper placement. It has to be on to on, so outer skin surface to outer skin surface.
Not bone to bone.
No. And we have to meticulously exclude common pitfalls like the yolk sac, which is often right near the head,
Wow.
or the amniotic membrane, or any little limb buds.
Because they'd add length.
They add length. They cause false elevation, overestimation of the age.
So we've covered the machine settings, the technical placement, but the sources say the biggest error, the one that's hardest to control, comes down to the baby's active posture. What's the ideal neutral position we absolutely have to wait for?
That's criterion 5. And it's critical. You have to clearly see a pocket of amniotic fluid between the chin and the chest. Audits consistently show that this, along with getting that perfect mid-sagittal plane, are the most frequent failings.
Really?
Yeah. Only about 27 to 40% of routine images actually satisfy all 5 of those ISUOG criteria.
That number is sobering. I mean, that means a majority of scans might have some inherent error baked right in. Let's focus on that position element, because our sources call it the most significant source of operator-dependent error.
It is the most challenging variable because it's dynamic. The baby moves. Studies show that a non-neutral position, so the baby being either curled up or looking up, can change the CRL measurement by anywhere from 8 to 17%.
Wow.
That is a massive swing.
Let's break down the mechanics here, because this is where that ripple starts. If the fetus's flexed chin is on the chest, that systematically underestimates the CRL.
Right. It measures shorter than it is.
Leading to underdating, delaying the due date.
But the more clinically dangerous error, I think, because it leads to all these unnecessary invasive procedures, is when the fetus is extended.
Looking up.
Looking up, chin high. This systematically overestimates the CRL. That means overdating, artificially advancing the EDD. And this is where that ripple effect turns into a full clinical cascade.
Walk us through that. A single error from fetal extension. What happens next?
It all starts with that over-measured CRL. That's used to set the artificially advanced gestational age. Then the patient goes for her first trimester blood work, the aneuploidy screen, and the laboratory has to reference that artificially older fetal age. And because a marker like PPPA rises so rapidly day by day, the lab expects a high reading, appropriate for that advanced age.
But the patient's actual PPA level is normal for her true age.
Yeah.
So against that advanced reference, it looks falsely low. It's the mom trap.
Exactly. A falsely low PPA mom multiple of the median drastically increases the calculated risk for trisomy 21.
Wait, so a single technical error hours earlier in the ultrasound room can lead a patient to believe her baby has trisomy 21.
Yes, and the emotional and clinical cost of that is staggering. You get a false positive high-risk result, massive patient anxiety, unnecessary follow-ups, and maybe even invasive testing like CVS or amnio.
For a perfectly healthy fetus.
For a perfectly healthy fetus. That technical error didn't just move a date, it changed a life for a few agonizing weeks.
And that error doesn't just stop there.
Yeah.
It follows the patient all the way to delivery.
It does. If that initial CRL error artificially advanced the EDD by, say, 10 days, you might induce a patient at what you'd think is 41 weeks. But biologically, she's only 39 weeks and 4 days.
That is the very definition of iatrogenic prematurity.
It is. And while 39 weeks is technically term, inducing a baby that's physiologically younger can increase induction failure rates, prolong labor, and potentially increase the need for intervention, all compared to a baby that goes into labor spontaneously at a true 41 weeks. The whole point of accurate dating is to avoid this exact scenario.
Okay, so far we've focused entirely on the sonographer's technique. But let's say you get a perfect 5-point compliant measurement. The next challenge is interpretation. Which reference chart do you use? There's been a real chart war over the last few decades.
It really has. I mean, historically, the Robinson and Slemming chart from 1975 was the default, the gold standard for decades. But we now know it systematically underestimates gestational age, especially for larger CRLs over 60 millimeters compared to modern data.
So where did the big shift happen?
The biggest, most impactful shift came with the Intergrowth 21st project, published in 2014.
And that's now the IOCheck G recommended global standard.
It is, and this was a highly rigorous international prescriptive standard, which means it wasn't just describing a population, it was derived from large, healthy populations across 8 different countries who met really strict inclusion criteria.
No smoking, no major risk factors.
Right, all to define what optimal growth potential looks like.
So the consequence of switching from an old chart like Robinson to this new prescriptive intergrowth chart must be pretty significant.
It is fascinating. Because the intergrowth chart sets a higher bar for optimal growth, the clinical consequence is a generalized increase in the diagnosis of small for gestational age later in pregnancy. The centile distributions shift.
So the new global standard is, in effect, forcing us to identify more pregnancies as high risk. That must have massive implications for clinic workflow, for surveillance costs.
Absolutely. It changes resource allocation fundamentally, and the drive for accuracy continues. I mean, we're already seeing new high-precision population-specific charts emerge, like the Zhang et al. Chart from China, which has a mean prediction error of only 0.32 days. They are squeezing every last fraction of a day out of the measurement.
This is where it gets really interesting, though, special populations. We have to talk about assisted reproductive technology, RT, pregnancies, because this is the ultimate test of accuracy, right? The date of fertilization is a known Tier 1 biological fact.
And when you compare the measured CRL to that known date, it exposes what the sources call the IVF gap.
The IVF.
ART pregnancies consistently measure larger or older by 1 to 2 days compared to their known fertilization date.
What's the theory there? Is it the hormones?
It could be. It could be the strong hormonal support in RT cycles accelerating early development, or maybe even the specific culture media used for the embryo in the lab. But whatever the mechanism, these babies are intrinsically 1 to 2 days ahead on ultrasound relative to their calendar age.
And because of this gap, the clinical protocol has to be absolutely non-negotiable. You cannot let the CRL overrule the fact.
This is the cardinal rule for ART, and it has to be followed strictly. You must never redate an IVF pregnancy based on the CRL.
Ever.
Never. The IVF date is the biological fact. It's Tier 1 reliability. If you redate based on a large CRL, you're artificially advancing the due date, and you're risking premature induction of a physiologically younger fetus. It's a major mismanagement risk.
Quick question on twins. How do you date spontaneous multiples? Average them.
No. For spontaneous twins, the protocol is to date by the larger CRL. The logic is that early undergrowth is just far more plausible than early overgrowth in the first trimester. But if they're IVF twins,
You stick with the fertilization date.
you bypass the CRL entirely and stick to the known date.
The need for quality here is crystal clear.
Okay.
Now that we've quantified the clinical impact, departments need structured quality assurance programs. This isn't just about correcting one error. It's about checking for systematic insidious bias among practitioners.
Absolutely. We need a structured QA approach with sort of 4 implicit pillars. First is the qualitative audit, just reviewing images against those 5-point criteria. Did they follow the rules?
A basic check.
Right. But the more rigorous check is the quantitative audit.
How does that system catch someone who's habitually off?
It works by analyzing the statistical distribution of a single sonographer's measurements over time. If a sonographer is systematically biased, let's say they habitually measure large because they tend to catch the fetus slightly extended, that bias can be detected. Laboratories actually use the PPPA-MOM distributions as an independent check on CRL accuracy. The established clinical threshold for unacceptable deviation is greater than plus or minus 2 millimeters of systematic error.
So if I consistently date babies 2 days ahead of everyone else, the blood lab is the one that flags my 2-millimeter error. That's an incredible feedback loop.
It is.
And given that human compliance with all 5 criteria is so low, that 27 to 40% number, this whole area just seems perfectly ripe for technological intervention. What does the integration of AI look like?
Well, the goal of AI is precisely to reduce that human subjectivity, especially around those difficult criteria like fetal posture and plane acquisition. We're seeing new tech like automated plane detection systems like 3D CRL net that can virtually navigate 3D data to automatically find the optimal midsagittal plane.
Which takes a lot of human skill and patience a day.
A lot. And then you have automating the placement of those finicky calipers, which could eliminate the pixel level error completely.
That's the smart calipers technology.
Exactly. AI algorithms auto-place the calipers precisely on the outer skin edges, minimizing all those user-dependent errors. Studies are showing that these AI models achieve an error margin of around 0.67 millimeters versus an expert.
So it's comparable to human inter-observer variability, or even better.
And that offers enormous potential to standardize precision across all centers, whether you're at a major teaching hospital or a small rural clinic.
But this entire deep dive just reinforces that the CRL is still the vital sign of early pregnancy, but its famed accuracy, that plus or minus 5 to 7 days, is only achieved when these standards are rigorously, almost religiously followed.
It demands technical discipline and clinical nuance in equal measure.
So what does this all mean for you? We've synthesized 6 absolutely mandatory takeaways, 6 mandates for the modern practitioner.
Number 1, adhere strictly to the ISUOG 5-point quality criteria every single time.
2, prioritize that neutral fetal position above all else. You have to wait for that pocket of fluid under the chin before you freeze the image.
3, select your dating chart deliberately. Use intergrowth for global consistency, but understand it changes your SGA distribution. Or use newer population-specific charts where they're validated.
4, and this is the big one, never redate ART pregnancies. The IVF date is the master biological record.
5, for spontaneous twins, always use the measurement from the larger CRL to date the pregnancy.
And finally, 6, participate actively in systematic audit programs, both the qualitative image review and the quantitative analysis, checking your work against that plus or minus 2 millimeter bias threshold.
Which brings up a really interesting question for the future, building on everything we've just talked about.
Go on.
If future AI systems can guarantee pixel-perfect, protocol-compliant CRL acquisition every single time, removing technical error completely, will our clinical focus shift entirely away from the quality of the measurement itself and solely onto interpreting the tiny biological variations, like that 2-day IVF gap, as the very earliest markers of pathology?
So if the measurement is always perfect,
Then any variability we see must be the biology. And that is something worth exploring.